Good evening, all. I'm Dr. Akshada Amonkar, a psychiatrist from Goa. And today we have Dr. Tanvi Pednekar, who is a very close colleague, uh, has been doing community service for a long time now. She's been giving a lot of talks, and this particular topic, is very close to her heart. She loves to discuss on this topic, and I think recently in November, November 24, I think she got a certificate course done from Nimhans, and she's got a certificate in perinatal psychiatry. So I think today she is here to give us more knowledge on the anxiety, which normally we kind of not ignore, but nobody looks at it with a perspective that it needs treatment or needs be spoken about. Every woman who is pregnant, she does go through this. I mean, even me, I think during my pregnancy, I would have had some issues which probably I've discussed with my friends. I was working back then in IPHB, so I used to discuss with my colleagues. I think Tanvi also was there around that time. But that becomes very important, and it is really not spoken about very well. So I think today she's here so that we as psychiatrists, we know how to pick the the soft signs of anxiety which can lead to like postpartum depression, which can be one of the precursors of postpartum depression. So here today we'll listen to her, we'll gain knowledge, and let's see what questions we have for her. So I welcome you, sir, Dr. Sudhir Bhave. Thank you for
Thank you.
being much before time for all of us. So sir always likes to have academic programs. Sir himself loves teaching. So I'm sure sir also will add on to this topic today. So I think, so I'll start with Tanvi. Let's let her begin.
Yeah, sure.
Yeah,
Oh,
you can.
thank you
Yeah,
so
Tanvi,
much.
over to you.
Yeah, yes. Thank you so much, Akshada, for that introduction. Okay, so let me share my screen. My screen visible?
Yeah, it is.
Yes.
Okay,
Yes.
yes. All right. So with that, I would like to first of all thank the Women and Child Committee to give me this opportunity to present on this topic. And without further ado, I think we can start with today's topic, that is perinatal anxiety. Let me start with array of these beautiful pictures. These pictures show that, and I can also say a simple observation that in India, we see a woman's journey into motherhood is always considered as very sacred and a celebrated event. There are rituals happening, there are celebrations, there's a strong community which wraps around the mother when she is either expecting or when she is a new mother. And as you can see in this picture, it's always the joyous journey that is seen. It is always the perfect motherhood and the perfect baby that is seen. But behind this perfect picture, somewhere, and behind the veil of this joy, there lies a struggle of her struggle of her anxiety, of many perinatal mental health issues that she goes through, which is often dismissed with comments by the society which say that you should be happy, not sad. It's just pregnancy hormones and it will pass. You're being dramatic. You should be thinking positive, focusing on the baby and not be selfish. But throughout this comments and throughout this judgments from the society, what goes on in her mind is the guilt, is the feeling that why am I not feeling happy, by the question that haunts her, that it is just me or am I weak, what is wrong with me. So today what we are going to do is that we are going to not only speak about perinatal mental health issues and perinatal anxiety as a clinical concept, but we are going to speak about the lived realities of countless of women. And as psychiatrists, we have a unique opportunity and we have a responsibility to step into this narrative and change this narrative. During our training, we are always biased, and rather we are trained and taught to look at the postpartum depression and postpartum psychosis mostly, but the perinatal anxiety is often dismissed and often misdiagnosed as the normal worry of pregnancy that is there. Hence, today we are going to challenge that bias. We are going to focus and put a shine onto perinatal anxiety and understand the why, what, and how of this perinatal anxiety. So let's address the first elephant in the room, that is normal worry versus perinatal anxiety. It is very common to have a lot of worry in pregnancy or when you are in postpartum. You might be thinking whether my baby is healthy or not, whether the delivery will go smoothly or not, whether I'm feeding the baby rightly, is he getting enough milk? There are so many things which are going. But these worries are mostly fleeting, they are manageable, and they do not disrupt your daily life. And they're usually managed by reassurance through a family member, a partner, or by a doctor. But when it comes to perinatal anxiety, these are unrelenting, they are consuming dread that is there, they are irrational, they are persistent. They are such struggles that cause you significant distress and that can cause functioning difficulty in your daily life. And hence, they require clinical attention. So let's understand more about this through a case scenario. Now, Ananya is a 28-year-old software engineer, married for 3 years. Married for 3 years. One second. With her first child, she has a loving husband and a supporting family. However, during a routine prenatal visit, the obstetrician noticed that Ananya was highly distressed. She reports she can't stop thinking about a fatal birth defect. Despite all the tests coming back normal, she spends hours on the internet researching every possible complication from placental abruption to cord prolapse. She obsessively monitors her baby's kicks, convinced that a slight change in the pattern is a sign of something wrong. She has started avoiding public places and large gatherings, convinced that someone will accidentally hurt her or the baby. Her family sees her as overly cautious and anxious, attributing it to her being a first time mother, but her husband reports she is barely sleeping and has lost her appetite. Now, this is a classic case, Ananya's case is a classic case of perinatal anxiety, how these worries are constantly there around her. They are not letting her function, they are not letting her bond with the baby, they are not letting her do her daily activities, and hence it needs clinical attention. Now, let's understand the second elephant in the room. Now, this is about prevalence and impact of perinatal anxiety. Why do we need to talk about perinatal anxiety so much? So, the percentage of pregnant or postpartum patient that usually struggle with perinatal anxiety it is said that anxiety or perinatal anxiety is the most prevalent among the perinatal mood and anxiety disorder, with the studies of prevalence ranging from somewhere around 15 or 14% to 27%. And it is also said that this might be just the tip of the iceberg. And in low and middle income countries where a lot of research is not done in terms of individual perinatal anxiety, it is found that it can be as high as 30 to 35%. Now, at this point, we also have to remember that when we are talking here of individual perinatal anxiety, most of the cases of anxiety do exist with depression. It is found that 30 to 58% of cases of coexistent anxiety with depression is seen. So this should be kept in mind, because as we go about for screening for anxiety, as we are going to understand about the assessment, we need to remember that if you find slightest symptoms of anxiety, you have to reassess the patient at a later date for depression as well. So it is said that perinatal anxiety affects around 1 in 5 mothers. Now, let's understand the risk and the protective factors in perinatal anxiety. And to understand better about this, we'll look at the biopsychosocial model through the lens of biopsychosocial model. Now, in biological factors, we have the hormonal changes, the endocrine function changes that happen, genetic predisposition, neurological changes that happen during pregnancy. Similarly, during psychological, we have the new stressors. Pregnancy itself is a very stressful period. Barrier to coping skills, which has always been there, history of psychiatric illness, any personality issues, difficulty in coping, self-esteem or temperament issues that have been there. In social factors, we can see that there is a role transition that is usually seen from a young mother. From a young girl, you're transition into a mother where there are a lot of responsibility, and your routine completely changes and starts revolving around this new member who is there. And there are a lot of changes which happen based on that. Societal expectation and pressures, as we have seen earlier in the pictures. Partner support, lack of partner support is again one of the risk factors. Then we have the intimate partner violence, which is one of the major factors as a social part. Now, these factors are for all the perinatal mood and anxiety disorders. Now, talking specifically about risk factors for the perinatal anxiety. Now, there could be maternal factors, pregnancy related factors, and psychosocial factors. Now, when we talk about maternal factors, any history of psychiatric or mental illness previously in the mother could be one of the reason. High perceived stress during the pregnancy. Now, high perceived stress means that there is a subjective feeling of inability to cope with the current demands and the situation that she is going through. There might be a lot of stressors around the high perceived stress. There might be financial burden, domestic violence, partner IPR with the IPR issues with the partner. So there could be a lot of strain that might be there that increases the perceived stress during the pregnancy. Smoking is one of the factors. Pregnancy related factors are mostly primary unwanted or unplanned pregnancy, negative childbirth experience in the previous pregnancy, previous stillbirth or pregnancy loss, preterm birth, complication during previous pregnancy, or an ICU admission that has happened. Psychosocial factors mainly revolve around lack of partner or social support, history of abuse, that might be any kind of abuse, domestic violence, and adverse life events. Now, there is one more factor that is, we can say that it is increasing day by day these days, and it is one of the factor that is usually not considered, and it doesn't come in the purview of perinatal anxiety per se, but I think it needs to be addressed. Now, for many women, the journey towards motherhood doesn't come as easy as it comes to most. It's not a straight line for everyone. We talk about infertility in mental health. Infertility is a medical diagnosis, but the psychological impact can be quite profound. It affects the patient. It deals Patient has to deal with the emotional roller coaster, the monthly cycles of hope and despair, the multiple failures that are seen, the physical demands of the treatment, the multiple injectables, and the financial burden creates a continuous state of stress, anxiety, and depression. Societal pressure. In the Indian context, the pressure of bearing a child is immense. Women are often blamed, leading to feelings of guilt, shame, and a loss of self esteem. The stress can put a severe strain on couples' relationship, leading to communication breakdowns and even marital discord. We often get cases for the patients who are started on IUI and IVF cases. They get referred to us because they are being told that your stress is a major factor why the IVF cycles are not getting success. But what they usually complain is that the stress is mainly that because every time the failure happens, there is a lot of disappointment that happens, and that leads to declining of the hope every cycle. Now let's talk about the impact of perinatal anxiety, or rather impact of untreated perinatal anxiety, and why are we saying that it is so important that we screen every patient for this. So when we talk about mother, in terms of mother, it is seen that there are higher cases of preeclampsia, increased nausea and vomiting that is seen, increased number of visits to the obstetrician, that may be because there's a lot of worry, there's a lot of worry that maybe something is wrong with the baby, so increased number of visits. Preterm delivery is usually seen, more difficult labor and delivery, PTSD symptoms related to the birth or fear about the childbirth. Many of them, with the fear of childbirth, usually go for elective cesarean section because they feel that they won't be able to bear the fear. Strong predictor of postnatal depression. This is very important. Two-thirds of cases of antenatal or perinatal anxiety are known to be a very strong predictor when it comes to postpartum depression and any risk of ongoing mental health issues. When it comes to infant, low birth weight, low Apgar scores, and ICU admissions, and there is increased risk of childhood disorders in terms of emotional dysregulation, behavior or developmental disorders like ADHD, autism. Some cases are seen. It also affects the mother infant diet. We talk about breastfeeding difficulties and bonding problems. But when we talk about breastfeeding is something which is always considered quite natural. It is usually told to the mother that as soon as you get your baby in your hand, you'll understand how to do it and there will be someone to tell you. But a lot of women have spoken about the difficulty in breastfeeding, difficulty in latching, a lot of constant worry that they have whether the baby is getting enough milk or not, whether I'm feeding the baby properly or not. So there are a lot of breastfeeding difficulty, and of course anxiety, a presence of anxiety can trigger, as well as the breastfeeding difficulty can further exacerbate the anxiety. Bonding issues, because of all this perinatal anxiety, it can lead to problem of mother-infant bonding. Other factors, risk factor, the perinatal anxiety is a major risk factor for paternal anxiety and depression, and it can also lead to a lot of financial difficulties. This was a study which was done in NIMHANS, and it was found that most of the anxiety. Now, when we speak about a normal anxiety disorder and when we speak about a perinatal or a pregnancy specific anxiety, what differs both of them is basically the theme around which it is usually seen. So, here are the five components around which it is usually seen. One is the fetal malformation, one's own physical appearance and health related to pregnancy, hospital related fear, delivery and labor process, and childcare. So these are the factors that it is usually seen. And as we have said earlier, how to differentiate it with normative pregnancy is basically based on the intensity, the persistence, and the negative impact on functioning that it puts. Now, we look at perinatal anxiety as a whole and we talk about the overall signs and symptoms. Then it will be psychological symptoms, wherein there will be uncontrollable worries, racing thoughts, intrusive, unwanted thoughts, feeling on the edge, and poor focus and difficulty in making decisions. Physical symptoms like that of palpitation, headache, sweating, nausea, muscle tension, insomnia, and dizziness. Now, a brief mention about insomnia. Now, many a times when we are taking a case when it comes to perinatal or postpartum mothers, and if you ask the mother, are you having any sleep disturbances? The mother would obviously say that since I'm feeding the child, I'm not getting enough sleep. So the best way to ask question in this way would be, when you are getting opportunities, when you get adequate opportunity to sleep, are you able to sleep or relax? Okay, that will help you to understand whether there are this racing thoughts or worries that are going on. If even if she is getting, like, when the baby is sleeping at that point of time, when someone else is taking care of the baby at that point of time, are you able to sleep or not? Okay, so then we talk about behavioral are mostly in terms of avoidance of certain behaviors. We'll talk about more cases as we go further. And reassurance seeking from the family, doctor, or partner, that is usually seen. These are the main signs and symptoms. Now, perinatal anxiety disorders are, these are the different types that are there. Generalized anxiety, there might be panic disorder, specific phobias like tocophobia, and obsessive compulsive disorder. And we'll also speak about the postpartum, the PTSD. Okay, so this is a beautiful book which is by Kleeman. It says, Good Moms Have Scary Thoughts. So these are some of the illustrations that are present in the book, wherein the images on to her mind are beautifully given. And there are some ways to deal with this is also given. These are some of the pictures I got from the online. So I've just put them. So what others say, what she replies, and what actually goes on through her mind. So let's start with eating disorder. I think generalized anxiety disorder, unanalyzed case that we saw first, can be a good example of a generalized anxiety disorder where there is excessive, uncontrollable worry about various aspects of life, including maternal and infant health. All right, devotes a significant time and psychological resources to worry. Panic disorder. Panic disorder will comprise of experiences of such panic attacks, which will have tachycardia, sweating, dizziness, like how a usual panic attack is there. Sometimes there is a higher possibility to misinterpret this as physiological symptoms for significant medical event. So many a times the patient might reach out to the obstetrician or to emergency service with the physiological symptoms, thinking that it is a significant medical event. Now let's see this. Sarita is a 25-year-old newlywed, 2 months into postpartum. She has always been a little shy, but since having her baby, her fear, her shyness has become debilitating. She is terrified of being judged by her friends and family. During a recent visit, her mother-in-law commented, "Why is the baby so fussy? You must not be feeding her enough." Sarita was mortified. Now she avoids all the visitors, refuses to leave the house, fearing she will be scrutinized for her parenting skills or that her baby will cry in public, confirming everyone's worst suspicions about her. She feels isolated and alone, even though her husband is supportive. So, this is a case of perinatal social anxiety disorder. Here, what is important is that Avoidance of social situations is usually seen, and it is mainly due to the fear of criticism or embarrassment. Now, this can be exacerbated by social pressures, which are usually seen related to childcare, the perfect mother picture, or related to breastfeeding. The next case scenario is about Ria, a 29-year-old woman, 10 weeks pregnant with her first child. She has a fear about delivery. This is not just a passing worry, it is a terror so intense that it has defined her entire life. Despite of wanting a child, she has put off pregnancy for years, and now that she is pregnant, the fear has become overwhelming. She has vivid nightmares of painful, gruesome birth, and her anxiety has led to panic attacks and severe sleep disturbances. She constantly demands a cesarean section, believing it is the only way to avoid the horrifying ordeal of vaginal delivery. But her doctor is hesitant. So this is nothing but tocophobia, fear of childbirth. It is common and more interest in pregnant nulliparous women than in pregnant parous women. Its incidence or prevalence is said to be 20%. Pregnant women usually report fear, and I think many of the obstetrician I recently spoke to, they told about that many a times after the first birth, the woman usually says that I don't want to have another pregnancy just because of the fear of childbirth. So childbirth trauma is something that is prevalent but not spoken much about, and this is very important to know. Primary cases are nulliparous, secondary previous traumatic delivery if there has been, or secondary to depressive illness in the pregnancy could be some of the causes. Now, Deepa, a 34-year-old mother, 4 months into postpartum, she had a dreadful birth experience that included an emergency C-section and complication that put her and the baby's life at risk, according to her. 4 months later, she's still haunted by the event and she has recurring nightmares of operating room and is easily startled by the loud noises. She's hypervigilant, constantly checking on the baby, panicking whenever a sound reminds her of the delivery room. She actively avoids talking about the birth and feel emotionally numb, detached from her husband and even her baby. The joy she was meant to feel is replaced by a crippling fear and a sense of disconnection from herself. This is example of peripartum PTSD. Now, it could be either prepartum, continuation of the prepartum fear, or it could be a new onset post the delivery. There are usually negative subjective experience of childbirth, either a subjective experience or a past history of trauma or PTSD, which is already there. Emergency LSCS, as we have seen in this case, and complications in delivery that might be present, instrumental delivery that might be present, and poor social factors, social support are also said to be the risk factors. So acute cases are said to be 4.6 to 6.3% and 16.8% of women in community. The next is a case scenario about Maya. She is a 30-year-old new mother. 6 weeks into postpartum, she loves her baby more than anything, but she is tormented by unwanted intrusive thoughts of accidentally harming him. She has vivid, disturbing images of dropping him down the stairs or smothering him in the sleep. She knows these thoughts are bizarre, completely against her will, which fills her with a profound sense of shame and guilt. To neutralize this thought, she hides all the knives in the kitchen, avoids carrying the baby near the stairs, and repeatedly checks on him dozens of times at night to make sure he is still breathing. She constantly asks her husband for reassurance, desperately seeking to silence the terrifying voices in her head. So this is a case of perinatal OCD. Perinatal period is known to increase the risk of OCD, unwanted intrusive thoughts, or mental images can be really violent. Now, compulsions are usually seen as repetitive, ritualistic washing, checking, counting, or reordering things, avoidance, concealment, like how she was hiding the knives, prayers, seeking reassurance can interfere with the caring for the infant. There is always a sense of horror about the obsession. They feel dreadful that how can I even have such kind of a thought? The fear of being left alone with the infant is always there. They might plead the family members to be there, don't leave me alone with the infant. There's a lot of hypervigilance in protecting the infant, and mother knows the thoughts are bizarre and are very unlikely to ever act on them. That is, they are the ego dystonic. When we talk about perinatal OCD, it is very important that there is a thin line between perinatal OCD and psychosis. We'll speak about that. So this is the same thing. Usually there are obsessions which say fear of fetal death during pregnancy, for which she might be having compulsion of checking for the fetal movements again and again, fear of contaminating the fetus by toxic agent, excessive washing and cleaning, and aggressive obsessions towards the fetus. Postpartum period, she might have fear of intentional or accidental harm to the infant. Sometimes it also involves sexual abuse, fear of for which she might have avoidant behavior, avoiding knives and infant in the first case, and compulsive checking of the infants, especially at night. There is always this intense fear of sudden infant death syndrome that is there in the mind, fear of contaminating the infant again, and fear of criticism of her mothering skills, which is because of the societal expectations. Now let's understand why we need to differentiate, or why there is a thin line when we say there is a thin line between perinatal OCD and perinatal psychosis. So when we talk about perinatal OCD, these are persistent, intrusive, scary thoughts and images. And similarly, in perinatal psychosis, we have intrusive, scary thoughts and images, but these images are not going to worry them. Like if you look at perinatal OCD, they are terrified of acting onto their fears, and the thoughts are not they are inconsistent with their self. They are ego dystonic and they are against their will. And they will do rituals and compulsions in order to manage those anxiety and fears, like avoiding and reassurance seeking. But in case of perinatal psychosis, these are usually accepted, good, they are helpful in some way. Sometimes they act on the ideas and delusions as well. So we can have an example wherein maybe a mother feels that my child is engulfed in a evil spirit. So for that, I have to hit the child to get the evil spirit out. So there is a high risk of potentially causing harm to the self or child, which is usually not there when it comes to perinatal OCD. There is usually a low risk of acting onto fears and obsessions. These are some of the medical conditions which have to be considered, especially when we train the obstetricians or pediatricians. They have to be informed about this, or the general physicians. It is said that diagnosis of GDM itself, gestational diabetes mellitus, increases the susceptibility to depression or anxiety 2 to 4 times more likely to have antenatal or postnatal depression, right? Hyperemesis gravidaria, also greater risk of perinatal mood and anxiety disorder. In case of pregnant women, commonly experience somatic and other symptoms in the first trimester may be the predictors for depression. Pre-pregnancy and antenatal depression or anxiety associated with hypertensive disorders during the pregnancy, and preeclampsia with preterm delivery is usually linked to history of depression over the lifetime of the woman. Now let's talk about assessment. How do we go about assessment of this woman? Now, when we talk about assessment, before we move on to the psychosocial assessment, there are two other factors which need to be assessed. One is CBC, that is a complete blood count, and second is the thyroid function test. Now, both of this, that is anemia and thyroid dysfunctions, are going to have symptoms which will be somewhere around mimicking the anxiety symptoms, something like irritability, uh, palpitations, tremors, or sweating, fatigue. All these things are somewhat mimicking that of anxiety symptoms also. So whenever you want to screen a patient, make sure that you are also ruling out these medical disorders before we move on to the main assessment. Now, talking about the assessment, psychosocial assessment is very necessary during the management part or assessment part. In this, we have to assess for the marital relationship. How is the support from the family? Is there any domestic violence that is involved? Is there any socio-economic status of the family? Any life events, cultural practices and beliefs? It is very important to the management, and the assessment has to be inclusive of the culture sensitivity, and including the partner and the family is very important whenever available when it comes to management of perinatal mental health issues. So what are the different screening tools that we have? So we already know about Edinburgh postnatal depression scale. So in the Edinburgh postnatal depression scale, we have a 3A subscale, which basically there are three questions which talk about anxiety, which can be used as a screening tool. We have the generalized anxiety disorder scale, which we usually use. That is also one of the validated tools for perinatal anxiety. Then we have the perinatal anxiety screening scale and the pregnancy related anxiety questionnaire, which has been released. Now, we'll just see about the EPDs. Now, the Edinburgh postnatal depression scale, as we said, there are three questions that are involved in this. One is I have blamed myself unnecessarily when things went wrong. And the answers are usually yes, most of the time, yes, some of the time, not very often, and no, never. So, based on that, it will be scored and the scores will be given. I have been anxious or worried for no good reason, and I felt scared or panicky for no very good reason. These are the three questions which EPDS uses. Now, talking about the perinatal anxiety scale. Now, this perinatal anxiety scales is a 31 item scale which basically ranks from 0 to 10. 0 being something bad is going to happen, fear that others will judge me negatively. So, these are all the things that are usually seen. So, what is done is that the anxiety severity is basically asymptomatic is 0 to 20 score, mild to moderate symptoms are seen at 21 to 41, and severe symptoms from 42 to 93. Now, as we have seen about the assessment, now we move on to the management of perinatal anxiety. How do we go about managing perinatal anxiety? Now, most of the time when we talk about perinatal mental health issues, we know that the first point of contact is usually not the psychiatrist. The first point of contact will either be a obstetrician, a pediatrician, or a general physician. So the assessment has to happen at that particular point of time so that the patient can get referred to us, and then we can begin with the management of this. Now, the first question that a patient or any family member will ask you when you're going to start assessment and start treating this patient is, doctor, the treatment going to be safe for the mother as well as the child? Is it going to affect the child in any way? Is it going to affect the fetus, or is it going to affect the infant through the breast milk in any way? And are there any options that can be avoided and we can go about for a treatment other than the pharmacological treatment? So let's understand what is the non-pharmacological treatment. Now, in non-pharmacological treatment, the first step is always the psychoeducation. Then we have psychotherapy, support groups, and some lifestyle modification. Now, let's talk about psychoeducation. Educating the mother and her family to destigmatize the condition is the most important thing. Family is the primary support, and engaging the husband and the mother in law and the family of the mother is crucial. Educating them how to provide emotional support and not just practical help can be a game changer. Many a times, providing with just a physical support like helping her sleep or so things can help, but giving her emotional support that these things will pass, it will help you. We are there here. These are some things which can really help the mother get through these challenging times. Support groups are something I feel are not going to work for each and every disorder. At times, it can be so that if there is a diverse group of different types of anxiety or depressive disorder, it might end up increasing the anxiety in some way when the patient is speaking. Okay, and as as still now, I haven't found any support groups which are there in person in and around. These support groups are usually seen in many other countries, but it can be helpful in some cases. Psychotherapy in perinatal anxiety. Now, psychotherapy in perinatal anxiety, that these are the three most used psychotherapies in perinatal anxiety. The first one is cognitive behavior therapy. We all know that cognitive behavior therapy revolves around the basic model of thought affecting our emotions and affecting our behaviors, being a vicious cycle. So, When we talk about cognitive behavior therapy, we don't say that the patient has to be referred to another provider or a therapist to get into the proper cognitive behavior therapy. But sometimes introducing small techniques from the cognitive behavior therapy domain or the model might help the patient. Some things like cognitive restructuring, training, problem solving, goal setting with the patient, behavioral activation strategies, and giving her some homework and practicing all these things might be helpful for the patient. Talking about the interpersonal therapy, now many a times in cases that we have noticed that most of the cases, act- at least I have noticed that most of the cases come with a background stressor of uh, strained IPR or strained interpersonal issues with either the partner or the in-laws or the family. So this is one of the strong risk factors, lack of social support, which is always there, and improving these relationships and helping her cope with this will definitely help in terms of improving the state of mind and the anxiety. Involving the family members again is very important. Just focusing on the patient and giving advice to the patient sometimes doesn't help. Involving the partner through the interpersonal therapy and the family members is always going to help. Mindfulness based therapy, explaining the patient about mindfulness, being in the present moment, making sure that she is doing all the different kinds of mindfulness activity, introducing the different kinds of mindfulness activity slowly and putting into practice something as simple as mindful eating, mindful walking, mindfulness meditation, even a few minutes a day can really help. Relaxation exercises like that of deep breathing, JPMR, grounding exercises, these are some of the things, small things that can help patient improve in terms of the anxiety. Now, this psychotherapy is mostly helpful in mild cases. Mostly moderate to severe cases might be requiring medication. There is one more therapy which is tried in perinatal OCD, which is exposure and response prevention therapy, which is usually done in terms of perinatal OCD. And of course, in post traumatic stress disorder, we can always work on trauma focused therapy as well. Now, talking about the pharmacological treatment. Now, when we speak about pharmacological treatment, the first challenge that you will face when you talk to patient about pharmacological treatment is the question that is it really required? How it is going to harm the baby, how it is going to harm the patient, how it is going to harm the future. So it is very important that we need to have a clear evidence-based conversation with the patient about minimal risk versus the severe risk of untreated perinatal anxiety, which can include from preterm birth to low birth weight to poor mother-infant bonding to numerous developmental and behavioral disorders that can happen at a later date. When we talk about antidepressants, selective serotonin reuptake inhibitors or SSRIs like sertraline are generally considered as the first line management and safe for most women during pregnancy and breastfeeding. However, SSRI takes certain time for the SSRI to act. So during that particular point of time, you might have to introduce a low dose of benzodiazepine, which can help you. Okay. Also, in case of severe anxiety or sleep disturbances, low amount of benzodiazepines can be included. Whenever you're using benzodiazepines, make sure that you use them with caution and only for short term. And when you're using, try to use the short acting ones like that of lorazepam. Whenever you're using benzodiazepine, another thing that you have to keep in mind is the withdrawal symptoms that might happen. Like there are different things like the floppy infant syndrome or adaptation syndrome that happen for which we have to be very careful. Now, few guidelines when we talk about the pharmacological part of perinatal mental health issues or perinatal mood and anxiety disorder. So, whenever you see a woman of childbearing potential, always discuss the possibility of pregnancy. Half of all pregnancies are said to be unplanned. So, avoid using drugs that are contraindicated during the pregnancy in women of reproductive age. Mental illness is newly diagnosed in a pregnant woman. In that case, try to avoid all the drugs in the first trimester when the major organs are usually found, unless the benefits outweigh the risks. That is, if non-drug treatments are not effective or appropriate, then use an established drug at the lowest effective dose. Now, what to do if woman is already taking a psychotropic drug, is planning a pregnancy now? Consideration should be given to discontinuing the treatment if there is no or low risk of relapse. But if the discontinuation of the treatment for a woman with severe mental illness is having a high risk of relapse, it is unwise, but consideration should be given to switching to a low risk drug whenever possible. So the main guidelines are: use the lowest effective dose, use the drug with lowest known risk to mother and fetus, prescribe a few drugs as possible, both simultaneously and in sequence. Be prepared to adjust doses. This is very important. We require adjustment to the doses, mainly as the pregnancy progresses. Dose increases are frequently required in the third trimester when the blood volume expands by around 30%. So plasma level monitoring may be helpful. Whenever not possible, you have to keep a watch upon the signs and symptoms. If you find that there are any changes in the symptoms, you might have to increase the dose accordingly. Similarly, we have to note the changes in the hepatic enzyme that by they are increased by 50% at the end of pregnancy, while the activity of the others are reduced by up to 70%. Considering referral to a specialist whenever required, ensuring adequate fetal screening is very important when the patient is on various drugs. Be aware of the potential problems, inform the obstetric team about the different complications that can happen, and monitor the neonate for any withdrawal effects after the birth. Coming to postpartum period. In the postpartum period, the worry is mostly about the breast milk and the transfer of drug to the neonate or the infant. Now, breast milk drug concentration can be used to estimate the daily infant dose. This is basically seen as a proportion of infant weight adjusted dose when expressed as a proportion of maternal weight adjusted dose, and it is called as the relative infant dose. Now it is said that drugs with relative infant dose of less than 10% are usually regarded as safe in breastfeeding. Where a mother has taken a particular psychotropic drug during the pregnancy, it is said, and until delivery, the continuation with the drug while breastfeeding will usually be appropriate, and this may minimize the withdrawal symptoms in the infant. So, it is very important to continue the drug rather than abrupt stopping, which can lead to withdrawals in the infant. And last but not the least are different lifestyle modifications and supportive measures that we can always talk about when it comes to this, which basically involves diet and nutrition of the mother, keeping a check on that, brief exercises which involve brief walking as per the different stages of pregnancy and postpartum. Sleep is something which is very important and often disregarded when it comes to pregnancy as well as postpartum period. And to put sleep at a proper place or to make sure that the sleep is adequate, what is mainly required is the family support. So, expressing the breast milk and keeping for the night, because most of the time, females will come and tell you that if you tell them that I'm going to put the medications at night so that, we can adjust the dose accordingly. What is the main thing that they tell you is, I put my child to sleep only by giving breast milk. This is what is usually he goes to sleep only by that, nothing other than that. So you need a lot of family support, a lot of social support, a partner support to inform the patient that there are some things that we can do around it. Express breast milk can be given. That could be one of the things that family member like partner or mother-in-law or mother can feed the baby at night in between the week, wherein the mother will get the required amount of rest in between. Okay. Similarly, yoga, mindfulness, as we spoke about, meditation, all these practices do help in some or the other way to relieve the stress and the anxiety. And of course, the support groups, or more than support groups, I can say, venting out your thoughts, speaking to a therapist, or coming to a obstetrician and speaking about your problems can definitely help. Key points: early detection, support, and collaboration. Let me speak about one case that I saw. Um this patient had always been a anxious personality disorders, had various trauma in her life uh, in terms of relationship issues, in terms of abuse, and she also had a family history. That mother was a case of depression and bipolar illness, unipolar depression and bipolar illness. And she had always seen her mother in and out of the hospital, and she always lacked that bond with the mother. She grew up, she always had trust issues, she had a lot of relationship issues basically because of that. And she had 8 years struggle of assisted reproduction problems, IVF cycles, multiple failures, multiple miscarriages, and she finally conceived. During the pregnancy also, she says that she had a lot of worry that my pregnancy might not continue, whether it will continue or not, what will happen. There was a lot of anxiety that was always there. But it was never considered by her also to be spoken to her obstetrician. She never spoke about it. It was only after the delivery, and actually at 6 months of delivery, when she was almost planning to join her job back, she was in a corporate job, that she started feeling this anxiety that how things are going to fall in place, how she will take care of the baby, how she will handle the job as well as the baby, whether she is going to cause problems to the baby, and there were a lot of worry. And she got referred, and this made the obstetrician feel that her worry is something more than the usual worry, and she got referred. Initially, we tried with a lot of therapy, a lot of counseling approaches, deep breathing exercises, relaxation, problem solving, but it wasn't helping. And then we had to introduce her to treatment, wherein we started her with sertraline and some amount of benzos here and there, which improved her in a better way. So it is very important that we understand that there might be a lot of factors involved, but what is important point that I'm trying to make here is that recognizing the symptoms of perinatal anxiety early can lead to a lot of timely intervention. If this patient was, noticed all these symptoms early, she would have spoken about it, there would have been a better outcome. That anxiety wouldn't have been so worse when it came to postpartum. So it is important that we detect it early, and for that what is most importantly required is a multidisciplinary approach, a collaboration between obstetrician during the antenatal part and pediatricians, because they are the ones who are going to see the patient postpartum. A mother coming with a baby who looks a little off, a simple question being asked like, you're not feeling well, you look little off, are you having some worries, can actually do wonders and understand and detect a lot of issues. So it is very important that this training and all these things have to reach out, as well as that community awareness that perinatal mental health issues exist and they are just not normal worries can help a lot. Continued support even after that, empowering them with resources. Um,
Understood.
there is a site known as the Postpartum International, which comprises of a lot of, for educated patients, you can always refer them to this. It has a lot of uh, material on different types of perinatal disorders, webinars and videos that they can always go about and see. And you can give them certain studies regarding the medication efficacy and the risk that is involved, the relative risk that is low, to make them understand. You can always give them all the studies to understand. So empowering change through professional training, public awareness initiative, and support group fosters a comprehensive approach to managing perinatal anxiety. So, what are the challenges? We all know that mental health is still viewed with suspicion and shame, and stigma still persists. We need to run awareness campaigns, destigmatize this condition. There are systemic gaps. There are severe shortage of perinatal mental health specialists and psychiatrists as well. Obstetricians and pediatricians are often the first point of contact, and we must train them to screen for these conditions effectively. There are a lot of social and cultural factors: a woman's low status, gender preference for a male child, and presence. The pressure from family to be happy, as we have seen, can all be significant risk factors. We need to work with the community leaders to address these systemic issues. So, at the end of this, I can say that what we have notice from the first slide to the last slide that it is not a joyous, motherhood is not always a joyous period. But as psychiatrists, we have the tools and we can guide them towards hope and connection and help them work towards a joyful motherhood. Thank you.
Thank you, Tanvi. It was a very extensive and elaborate explanation of perinatal anxiety. Plus, I think you have touched a little bit on postpartum depression also, and given us a good view, purview about how to go about and like work with the obstetricians. A lot of people involved, families. I think this is what is very important, that the families come in touch with the psychiatrist, and they
Yes.
also kind of get involved in the treatment, and that's when even I have seen that the patient gets better response and responds very well to the treatment. I would like to ask Bhave sir uh, to give us feedback on Tanvi's presentation, and then probably we can start the questions after that. Sir, over to you.
Oh, yeah, sure. Thank you. I must say that, I mean, it was a wonderful presentation. And when I say that it's not a cliche, but I really liked it. I mean, it was very comprehensive, great clarity of thought, very pragmatic. And I especially like the portions where Tanvi, I mean, differentiated normal anxiety from worry. I mean, I quite agree that anxiety during pregnancy in the prenatal period is often, I mean, brushed aside saying कि ये तो होना ही है, pregnant है, तो वो होने ही वाला है. But then, yeah, I mean, she made it very clear that an understandable concern and anxiety is much different from, I mean, a pathological anxiety. I think I'm fairly certain that listening to the talk is going to increase the empathy of even the male psychiatrists in the audience towards a female who is undergoing the rigors of pregnancy and the prenatal period. Extremely well explained, Tanvi. Artist,
Thank
congratulations.
you. Thank you.
Yeah, and before I mean, close my words, I mean, this perhaps, Akshada is the last program of the Women and Child Mental Health
Yes
Committee,
sir, yes sir.
right?
Before the because now Navratri will be coming up, and then we'll be heading towards the west zone, right? So I don't think we'll be able to.
Yeah. So Akshada,
So
you
unless you want us to have anyone more, unless you want us to have one more, we
I
can
would
push
like
it.
to overburden the subcommittee because we are going to have the, I mean, the Zonal conference only 3 weeks from now. But I mean,
Yeah.
close by really praising this subcommittee. I mean, which is perhaps the most active and the most productive subcommittee of the West Zone. I mean, every single month, I think, right from December, right, Akshara? So, I mean, this,
Yes, sir. We've
uh,
been having some program. Madam has been very active, and she's pushed us to do one program at least. We also had one in person at in Goa.
yeah.
So that's what we've
That
had,
was
yeah.
the 11th program. Yeah. So I think it's
Yes.
been a wonderful journey. So thanks a lot, Akshada, and all your team
Yes.
members and
Most welcome.
Chairperson Dr. Ratambara. I think she's not here today.
She's not there. Dr. Swati had joined. I think she's still there.
Okay.
I think Dr. Ritamba couldn't make it today. Dr. Swati and Dr. Neha are there from our subcommittee.
Right, right. And I would like to take this opportunity to invite both Akshada and Tanvi to the Nagpur West Zone Conference, which is about 3 weeks from now. So, I mean,
So
not
I think Dr. Hegde also is on the this thing. Our senior psychiatrist from Goa, Dr. Hegde he has joined. Dr. Veena. Yeah,
I
yeah.
can see the names. Yeah.
But has joined. Yeah.
Oh, as the West Zonal President and one of the organizers of the West Zonal Conference in Nagpur on 10th, 11th, and 12th October, I invite all of you, and it's a request, and I'm certain you will honor this. And my last words are, I mean, praising Tanvi's very rapid rise to being a senior faculty, because I recall 5, 6 years back she was that continuous anchor in a Goa conference, right, Tanvi? है ना?
Yes, sir.
The visual
Always.
so
Even now
continuous,
we haven't left her. Even now she is.
because those continuous anchors are people who are fairly young and I mean who won't mind anchoring for the whole day. From that position to a valued faculty, I think that's very justified and rapid rise. So my compliments, Tanvi.
Thank you so much, sir. Thank you so much.
Thank you all. Thanks.
Yes. So I think we'll go towards the questions. I think one question which is there here is Gaurav has asked, is there any merit in having continuous collaboration with our OBG colleagues to screen perinatal mental health issues? and how to practically reduce birth trauma perception.
There is definitely is going to be a lot of help if we have a continuous collaboration with the obstetricians, and it is very important not only the obstetrician but also the pediatricians, because these are two point of contact which are going to find the most cases. Now even in the district hospital we see most of the cases getting referred to us when they notice this. Of course these are the IPD ones which get referred, but otherwise also it is very important, because if they being the main contact, the first contact that is there, it is very important that they are aware about the different signs and symptoms so that they can pick them up early and refer the cases to us. Teaching them even simple techniques for mild anxiety will also help in terms of counseling techniques or something like that, which will definitely help them and empower them also to help such patients. And this course that I had done, I remember there were a lot of obstetricians from the Nimes course that I attended. There were a lot of obstetrician lactation consultants which were present, who wanted to know more about perinatal mental health issues, as they were seeing a lot of cases during their daily practice. So yes, awareness is happening, but we need more and more awareness to happen. Childbirth trauma again is one topic which is not widely spoken about, and the birth trauma perception is also such that people are not that thinking about that it might be so traumatic to anyone. This was at a recent CME that I had done for IME. That time, one or two obstetricians, they spoke to me and they said that we have noticed in our practice wherein, after one birth, usually the woman comes and says that, doctor, I don't want to go through another pregnancy. And when asked why it is basically because of the trauma that she has had because of LSCS or the vaginal delivery that she has basically heard or she has experienced. That is the reason why she doesn't want to go about it. So more awareness, as much as awareness that we create among community as well as among our doctor colleagues, it is going to help us more and more to deal with these issues. Yes.
Yeah. Any more questions, students? Dr. Veena, Dr. Hegde, sir. Any questions, anyone?
Nice presentation.
Thank you, sir.
Or just
Yeah.
you have not
Yeah.
mentioned the importance of counselors or psychologists,
Mm.
or psychiatric
Yes.
nurses,
Yes.
or
Yes. Yes.
psychiatric social workers, because
Yes.
these are
Definitely, sir.
bridges for
Mm.
health education and
Yes.
preventive steps between the psychiatrist and the obstetrician.
Yes.
So is
Yes. Definitely,
so
sir.
so I want your comments on this part.
Yeah, sure, sir. So I was basically speaking about the first contact where they will come in contact with a doctor. That is usually the obstetrician and pediatrician. So that was my focus. But of course, apart from that, as said that lactation counselors, which are there, even in our district hospital, we have a lactation counselor who is there. So even making her aware about these issues, telling her that how counseling them or how all these issues come up, what are the signs and symptoms can also help. Now, about psychologists, psychiatric social workers, uh, I can consider them when they go out to the periphery, maybe. Per se, them getting referred to a case, if they are getting referred a case through obstetrician or pediatrician, they might see a case, but otherwise, direct contact with them might be little difficult. That is my opinion. But of course, making everyone aware, we have a multidisciplinary team when it comes to psychiatry. We have the psychiatric social workers, the clinical psychologists, the psychiatric nurse, and we have the peripheral workers also when it comes to, like, when we speak about training of the health workers, the CHOs and the multipurpose health workers and ASHA who are there. These are very important. We don't have ASHA in Goa. We have only multipurpose health workers in ANMs. But when we speak about India, even if ASHA who go to house to house, they are midwives and all of that. If even they are made aware and they are given training in terms of perinatal mental health issues, it is definitely going to help. So it's a big multidisciplinary team, sir, and we have to work with all of. Thank you.
Okay, thank you.
Can I ask you a question, Akshada?
Yes, sir, please, sir. Go
Yeah.
ahead.
Tanvi, is there any data on, I mean, what percentage of women
Hmm.
following prenatal anxiety do not want to have a second conception?
Sir, on perinatal anxiety per se, there are very few studies. The research has not been that much directed on individualized perinatal anxiety. There is a lot of research when it comes to postpartum depression, postpartum psychosis, but there is very few studies which are there. But I haven't come through a particular study like this, but I can go through it and find out if there is any.
Sure. Thank you.
Yes.
There's a question from Chinar. Any role? What is that, Chinar? Tanvi, can you read? I think I don't know what it is. Any role of some
Uh,
classes in thing?
So I
I have
think
not.
these are classes basically to increase the confidence of mother, which are not that
How do you
prevalent
pronounce that?
here.
Lamas? How do you pronounce that?
Lamas,
La-
lamas. I think
Lamas.
Chinar can
Yeah,
lamas or
Lamas.
lamas, even I'm not lamas.
Lamas. Okay, fine.
Okay.
I never heard
So
of.
this basically help the pregnant woman to understand how to cope with pain and all of these things before pregnancy. Now, there are some more
Oh,
things in other countries like doulas are there. So usually doulas are they usually help with pregnancy during delivery. They are there with you the full time. We don't have something called as doulas here. So doulas are also very helpful, mostly in other countries. They help the mother go through all these phases of pregnancy, of postpartum, and they are always there to support them in most of the issues.
nice. Okay.
Namaz is
Good. Something new learned. Oh, any more questions? No more questions, then can we end? So can we end the session today? Think we're done. So thank you everyone for attending today's session. It was a great session. I think Tanvi has very well explained to us every aspect of perinatal anxiety. And I'm sure I have also learned something new from Chinar and Tanvi, Lama's classes and Dulos. So so I think yes, we all have learned something new. Thank you so much, Tanvi. I hope we
Thank you
get to
so
hear
much.
you more often. Okay, I'm sure Sir has heard you today, so Sir is going to give you more opportunities.